Bismillahirrahmanirrahim. I am Dr. Jamil from your Physiology department, and this discussion or the lecture is in continuation with the renal physiology. I have told you in details regarding the juxtaglomerular apparatus, and this diagram I have shown you earlier, but I have added one more thing here, that there's a mesangial cell. If you look at this 5B or written over here, the 5B, these are known as the extraglomerular mesangial cells. These are all again the part of your juxtaglomerular apparatus. And here you have got the intraglomerular mesangial cells. But I have told you, I have given you an idea that what is the actual anatomical position of this juxtaglomerular apparatus, the previous one, by making how you can understand it. But today I am going to show some diagram through which you can well understand the anatomical position of this juxtaglomerular apparatus. I have told you already, explained already the function of this one, that it is going to receive, sense your pressure and sense the sodium, and ultimately it is going to control the autoregulation of the GFR. Now the function of this mesangial cells, although it's not proved, but it is supposed that they produce renin and erythropoietin. These are extra glomerular mesangial cells. Let's see some other diagram through which you can conceive a good idea regarding this anatomical position of the. Look at this diagram. Here I have told you that the diagram which we will study is not the actual one, that the stretched form of the your nephron. This nephron, this is your loop of Henle, and this is your Bowman capsule. Here, if you can follow this cursor, Bowman capsule, the glomerulus, and this whole is your PCTs, and ultimately we dip down into the medulla. That's your loop of Henle. When you move up the thick portion, and this is the initial portion of the distal convoluted tubule, where it is that is going to pass between the afferent and the efferent arteriole. This is the actual anatomical position, that the initial portion of the distal convoluted tubule crosses or passes between the afferent and the efferent. And this area, if you analyze this area, you move to this another diagram. This is your Bowman capsule and the glomerulus all over the PCTs and loop of Henle and this and that. And then we reach to this area, the part of the distal convoluted tubule, where it is going to touch your, or you can say between the afferent and the efferent arteriole. If you analyze or you capture this area, then the cells of the nephron distal convoluted tubule which are facing towards the glomerulus, this is the cut section. These are the cells which are facing, or these are the cells, or this is a cut section of what? This is a cut section of the distal convoluted tubule which is facing towards the glomerulus. They become dense and they are known as macula densa, and we have got the juxtaglomerular cells which are thought to produce the renin, and I have told you that it is supposed that renin is also produced by the extramesangial cells. So this was a brief review of the previous, just to make you understand the anatomical position of the juxtaglomerular apparatus. And through this diagram, again you can see this diagram is very much explanatory, that this is your initial portion of the distal convoluted tubule that is coming down this area, these epithelial cells which are facing towards the glomerulus. And these cells, they are known as the macula densa, which sense amount of sodium coming up into the filtrate, and these the afferent arteriole, the efferent arteriole, and these cells are the juxtaglomerular cells which are supposed to produce renin. The renin is produced, and then ultimately converts your angiotensinogen into the 1 and 2, and ultimately vasoconstriction is there. So this is all about the juxtaglomerular apparatus, a brief review of the previous one. We are not moving towards what are the different factors which are controlling your GFR. Another theory regarding the autoregulation of GFR. Another theory that is known as the myogenic theory or myogenic mechanism. There, under normal conditions, the mean arterial pressure is 80 to 180 millimeter of mercury. Renal autoregulation maintains the nearly constant GFR. That means GFR remains constant despite a wide variation in the blood pressure. That mean arterial pressure may remains between 80 and 180, but your GFR, your blood pressure can vary. The mean arterial pressure can vary, can be between the 80 to 180, but your GFR remains constant. The myogenic theories, here is the myogenic theory. It's very simple to say. Suppose if your blood pressure is going to increase, whenever your blood pressure, suppose it is going to increase, your blood pressure increase, then what will happen? Your afferent arteriole will stretch. The afferent arteriole, which is receiving the blood from the heart, is going to be stretched or distended because of excessive arterial pressure. And the smooth muscles which are present within your blood vessel, they will immediately show contraction due to the initial stretch, because muscles, they behave like a rubber. When you stretch them, they will try to maintain their original position. They will go back to their original position. Whenever you release the pressure, they will go back to the original position. So when the excessive, or you can say high blood pressure is there, afferent arteriole stretches and the endothelium, or sorry, smooth muscle present within them, vascular muscle, they show contraction in response to that stretch. And this contraction, the arteriole resistance offsets the pressure in case that it is going to neutralize the pressure which is increased. That means, again, try to understand this one. Although this is a theory, this we are not confirmed about, but this is a theory that when your blood pressure rises, hypertension is there, more blood moves to the afferent arteriole, it causes the stretchness of the afferent arteriole, it is going to dilate, and immediately smooth muscles show contraction in response to that stretch. When the muscle contracts, that dilatation or that increase excessive dilatation will again show the constriction. So excessive blood will not allow to move into your glomerulus, and when excessive blood will not move there, your GFR remains constant. Offset means to neutralize the things. So arterial resistance offsets the pressure increase. That pressure that was increased, that is going to increase your blood flow. It is offset by the your arterial constriction or increase the resistance. So GFR remains a constant. This is another theory regarding this one. Let's move to the next topic, that is the what are the different factors which are going to control your GFR. One of the most important factor which is controlling your GFR is the hydrostatic pressure of the glomerulus. As I have told you earlier in the previous lectures that hydrostatic force is the outward force. Hydrostatic pressure is basically the pressure of the stationary water in the column of the water exerting its own pressure and the barometric pressure. The total one is known as the hydrostatic pressure. This hydrostatic pressure basically depends upon your systemic blood pressure. So this is the basic or the primary manipulator by which the GFR is regulated by the physiologically. Normal hydrostatic pressure of glomerular is 60 millimeter of mercury. We have seen in the previous slides. Now, if there is increase in the hydrostatic pressure, it will increase the GFR, and if it is decrease in the hydrostatic pressure, it will decrease the GFR. But this increase in GFR and decrease in GFR, actually it is maintained within the normal limit through your auto-regulation of GFR. But if the blood pressure is going to rise beyond that limits, which I have told you earlier, then definitely there will be a change in the GFR. But it is said now that whenever there is a rise in blood pressure, some GFR, or to some extent GFR definitely increases. So hydrostatic pressure of the glomerulus depends upon the systemic blood pressure. If blood pressure is high, GFR will increase. If blood pressure is low, GFR will decrease. The first thing. Second is the fact afferent arteriolar resistance. Afferent arteriolar resistance and efferent arteriolar resistance. These are the two very important things. Afferent arteriolar resistance is very simple. I would like to move to a diagram. Wait a minute. Here is it. This is your afferent arteriole, which is draining the blood into the glomerulus. This is a theoretical diagram from the guidance. So if afferent arteriole is going to constrict, definitely blood flow to this area will decrease. If it is going to be dilate, blood flow to this area is increased, And increase the blood flow will increase the GFR, and decrease in the blood flow will decrease the GFR. Very simple thing to understand. But here, if we move to the efferent arteriole, there is a complicated procedure. Whenever the efferent arteriole is going to be a constriction of the efferent arteriole, and this usually occurs under the effect of your angiotensin 2. So the effects, or you can say the effect of angiotensin 2 or constriction of this efferent arteriole has got dual effects on your GFR. If the constriction of this efferent arteriole is less than two-thirds, if it is less than two-thirds, or some books say if it is half than the normal, then the GFR is going to increase. How GFR is going to increase? That whenever the constriction to this area is increased, definitely blood which is coming to this portion is move, instead of moving onward, it will move in this direction. It will move down in this direction. We have seen earlier that the GFR is going to increase if this area is going to be constricted. Constriction of the efferent arteriole increase the GFR. But to some extent, once the GFR is increased, definitely plasma is filtered out over here, but proteins, albumin, they are getting accumulated over this area. Because proteins, they are not allowed to move to cross this area, so proteins, they are getting accumulated. So once the proteins, they are more in this area, albumin, when the albumin, there is more area, in this area is more amount of albumin is accumulating here, definitely their oncotic pressure is going to increase. And whenever this oncotic pressure, you know that it is trying to resist in the GFR increase, because arrow is showing upward, is trying to retain the water with them. So initially, when their constriction is less than one-third, then there is a GFR is increased. Whenever the constriction, the GFR is going to increase. And when this constriction is more than two-thirds, at that time, when the constriction is more than two-thirds, then due to the accumulation of more and more proteins over here, your GFR is going to decrease now. So initially, efferent arteriole, inferior arteriolar, efferent arterial constriction has got dual effect. Initially, it will increase the GFR, and later on, it is going to decrease the GFR. That decrease in GFR is due to the excessive accumulation of the proteins, that's albumin over here. Then another very important thing, if due to any reason this colloidal osmotic pressure is increased, if this pressure, then more proteins are accumulated over, definitely it will decrease your GFR. And if these proteins are less in your body, then this will increase the GFR. Here you can understand this. Actually, keep in mind one very important thing. Your albumin is produced by the liver, and it is lost through the different diseases through your kidney. So hypoalbuminemia is usually due to the defect in the production. Whenever there is a liver disease, the production is decreased due to that diseased liver. And if liver is normal, production of albumin is normal, even then, if your kidney is not normal, if your kidney is diseased, then it will cause the loss of protein through the kidneys. So hypoalbuminemia, the major cause is either in the defect in the production, that is the liver, or the defect in the loss of the proteins, mainly the albumin, through your kidneys. So if this colloidal osmotic pressure, if the proteins they are more, they will resist in the GFR, they will decrease the GFR. If the proteins are less, the GFR will increase. Then we move to this area, the Bowman capsule. If this hydrostatic pressure is more in this area, in the Bowman capsule, more, why it become more? It become more, if you can well understand the next lecture, because ultimately this Bowman capsule is the initial portion of your nephron, and nephron ultimately is going to drain in through your ureter. All the urine formed by the kidney is drained into the bladder, and then is passed onward through the urethra. So if there is any obstruction in the ureter, or if there is any obstruction in urinary bladder, so the flow of the urine will not occur. It will rise this, it will going to raise this pressure, and it will decrease your GFR. So this is again important thing. Back to that diagram. We have seen this one already. So we have seen this already. Afferent arterial constriction Then efferent arterial constriction. I have told you that the constriction of the efferent arteriole has dual effect. Less than one-third will increase and more than two-thirds will decrease the GFR. I have told you the reason behind it. Then the oncotic pressure I have told you earlier, that its increase will decrease. The GFR, so you can say the reverse is there. Increase will decrease the GFR, or decrease in oncotic pressure to glomeruli will increase the GFR. So this is opposite one. And oncotic pressure depends upon what? It depends upon your albumin, the quantity of the albumin. If the albumin is more, it will decrease the GFR. Then the hydrostatic pressure, the Bowman capsule, obstructive uropathy. I will give you the details of this obstructive uropathy, but it is going, I have told you a few lines before that this hydrostatic pressure can be increased due to the stone in the ureter or due to the obstruction in the urethra. Then it will raise the pressure and of the Bowman capsule. Ultimately, it's going to decrease the GFR. Then the atrial natriuretic peptide, which is coming from your atrium. Atrial natri means sodium, peptide means peptide protein. Atrial natriuretic peptide, whenever your atria are dilated due to the overburden, due to stretch, then it is going to produce an hormone which is known as the atrial natriuretic peptide. It increases the blood flow, dilate the afferent arteriole. So whenever the afferent arteriole is dilated, it will increase the GFR because more and more blood will move to the kidney, increase the GFR and decrease sodium reabsorption in the distal convoluted tubule and beyond that one, leading to the natriuresis, diuresis, and decrease in the blood pressure. Natriuresis means loss of sodium in the urine. Diuresis means polyuria, more and more your passage of the urine, and decrease in the blood pressure. Then stimulation of the renal sympathetic system. It will decrease the GFR by the vasoconstriction of both efferent and the afferent arteriole. Then prostaglandin, the bradykinin, nitric oxide, they act as a vasodilator, increasing the blood flow. Whenever there is vasodilation, they will increase the blood flow to the kidney and thus increase the GFR. Then lesions of the glomeruli itself. The very important lesion is the glomerular nephritis. I will tell you the details of this glomerular nephritis. When we are studying the glomerulus, we have to study this one also. Soon we are going to moving toward the glomerular nephritis. It's the lesion which is affecting your glomerulus. It will decrease the GFR. Then the amount of functional renal substance. That if your kidney is more in you can say substance is more, mass is more. If it is decreased, GFR will decrease. Amount of functional renal substance. If it is decreased, that means if your kidney is atrophic, it is reduced in size, then it will decrease the GFR. But a small decrease in substance has no effect. The small atrophy has got no effect. But this, if you can say the major more atrophic kidney, then it will cause the decrease in GFR. Then high protein diet. High protein diet increase the renal mass and through increased reabsorption of amino acids with the sodium in the PCT. When we will study the absorption of the sodium, reabsorption of sodium and the amino acids along with that, then you can well understand. At this moment, just keep in mind the high protein diet increase renal mass through increased reabsorption of amino acids with sodium reabsorption. Then hyperglycemia also increase your GFR. High protein diet also increase the GFR, and this hyperglycemia also increases your GFR because it's going to increase the sodium reabsorption in the proximal convoluted tubule. We will see later on how the diabetes is going to damage your kidney. Then you can understand how the hyperglycemia is going to raise your GFR. Actually, it is a change in the amount of sodium before maculodensa which affects the GFR. I will tell you details in the coming lectures why the hyperglycemia is dangerous, because I have told you that diabetes mellitus, that is a disease of sugar in the common layman terminology. Sugar is the most common cause of the renal failure in our country, but not in our country, but the rest of the world also. So how it's going to damage your kidney, we will see when we study some pathological features. So these are the factors which are going to control or factors affecting the GFR. Now, the next thing is acute glomerular nephritis. This is a common disease in our society, in our, you can say in Pakistan, it's very common, acute glomerular nephritis. uh, how it's going to occur and how it's going to damage your kidney. Basically, there is a bacteria which is known as Streptococcus hemolyticus A, the complete name, or simply you can say the streptococcal infection. This streptococcus usually going to affect your throat. Throat infection is usually done by this streptococcal infection. And this throat infection ultimately may be treated by your antibiotics. But some antibodies are formed against this streptococcal infection, or you can say streptococcal bacteria, the antibodies are formed. Then this antigen antibody complex, which are known as the immune complexes, they are formed and they are deposited in the glomerular basement membrane. What happens once you have got infection, sore throat due to streptococcal infection, then antibodies are formed against this infection in this bacteria, and then antigen antibody complexes, they are going to be deposited in the basement membrane, the glomerular basement membrane. Then the complement system is activated. Then what will happen? It will cause the immune injuries, that your immune system is going to injure your glomerulus. What's going to happen here? The cellular proliferation is going to occur, capillary lumen narrowed, and glomerular blood flow is decreased. Then when the glomerular blood flow is decreased, it will decrease the GFR. Oliguria, that means no urine, or no urine means very small amount of urine you can buy, oliguria. Then GFR will cause the distal sodium reabsorption. I will told you to, when you study the sodium reabsorption, then you can well understand this one. Then when the GFR is decreased, the retention of water and the sodium, then it will cause a rise in blood pressure and ultimately edema and the hypertension. Actually, what happens? These infections usually occur in the children at the age, you can say, between 3, 4 up to the 8 to 10. This infection going to occur, and we give the antibiotics, particularly we give the penicillin, and the patient usually feels better. His fever is relieved and he feels better. But after a few days, the mother comes to you with his child, with a child that he has got swollen eyes, he has got puffy face, he has got the swollen ankles. Immediately you should go for the urine complete examination, or you can urine detail examination. What happens there? You will find in the urine you will find the albumin. Why this albumin? Because your basement membrane has been damaged, due to which the leakage of the albumin is going to occur. So the albumin will be present, proteins will be present in your urine of that patient. Then what happens? You will also find the hematuria. Hematuria mean blood, presence of the blood in the urine. This is known as the hematuria. Why this hematuria? Because your glomerular basement membrane is damaged, fractured, and the blood is going to lose into your urine. So if the hematuria is there, actually the patient says the proper words by the mother that her child is passing a coke-colored urine. Coke-colored urine, the dark colored urine. That dark color is due to the presence of the blood, RBCs present in your urine, will lead to the hematuria. And this hematuria and proteinuria, these are the cardinal signs of this acute glomerular nephritis. And this acute glomerular nephritis is not going to cause immediate damage. Although damage is there, but the patient usually recovers from this area, from this disease. But after 10 years, after 15 years, he may go into the renal failure. He may enters into renal failure. And then then the patient realizes, the mother says that in the childhood he has got such an infection, he's got puffy face, he has got this and that. So this infection, and whenever we are going to treat this one, because immune response is there, and again a bacteria is there, so we have to give the antibiotics, we have to give the steroid to reduce this immune response, because your immune system can be suppressed by given the steroids. You have already seen the steroids which are coming from your adrenal glands. Cortisol, the cortisol is going to suppress your immune response, because it is going to suppress the production of your lymphocytes, both the T and B lymphocyte, their production is reduced. So we have to reduce these immune injuries. That's why we have to give the both the things. We have to give the antibiotics, particularly the penicillin related. We have to give the steroids for the treatment of this one. At the same time, we have to give some diuretics just to relieve the edema. Our diuretics are actually name of those drugs. We will see all the diuretics, their mechanism of action, their requirements, how they are used clinically in the coming lectures. So to relieve the edema, there is accumulation of fluid in the interstitial tissue spaces. We have to give the diuretics. So to relieve, to save the patient from the immune injuries, we give the steroids. To save the patient from the further infections, we have to give this one, penicillin infection for the streptococcal infection, and we have to give the diuretics for the treatment of this one. So this was all about your acute glomerular nephritis. Here the same things are there, and you can say this is the pathogenesis. The two most widely opposed theories include the glomerular trapping of the circulating immune complexes and in situ immune antigen antibody complexes formation resulting from the antibodies reaching with either the streptococcal components deposited in the glomerulus or with the actually this all I have told you. This in the you can see few lines earlier I have told you all these things. So this was all about the factors controlling your GFR and acute glomerular nephritis. We will see you in the next coming lecture with the urinary bladder. Thank you very much.